Good morning, everyone. Starting over again. So I'm Dr. Deborah Manst, and this is the third year of the Survivorship lecture series. We had a last-minute speaker change, and so I'm going to reprise my talk I gave 2 years ago on the principles of cancer survivorship. So I will go ahead and share my screen and start my talk. Let's see. Forgive me just a second. I'll need to share it. And I forget how to do that on Google. I think it's here, up here. Okay. So, wow, this is not correct. Hold on. Sorry, technical difficulties as is customary for Zoom meetings. So I've been literally editing my slides up to the talk. So again, this is just a brief overview of the principles of cancer survivorship, which I figure I haven't given this talk for 2 years. I don't know if any of you were attending these at the survivorship lecture series 2 years ago. So this is a good recap of just what we do and what we think about. And I first would just introduce myself again. I'm Dr. Deborah Manst. I know not all of you actually know me, but I've been with UIC now for about 3.5 years, seeing patients in the cancer survivorship clinic. So I'm attending. I see patients in cancer survivorship. And next week, it's actually going to be my last week seeing patients, handing it off to my very capable colleagues. But I have a background in preventive medicine. I did my residency at Cook County with our current director of cancer survivorship. And I learned there just a lot of kind of holistic, comprehensive care. So this was a real natural fit for me to get into this. I've since given many talks on this topic. I participated in the NCCN, National Comprehensive Cancer Network, recordings and gone to meetings, and just really gained a lot of knowledge in this field over the past several years. So I want to share all my experience with you. Of course, feel free if you have any questions. This is kind of a, very talk freely. And if you want to ask me a question as I go on, feel free to take yourself on mute. So going down to basics, the definition of cancer survivor. I know this is still fairly new topic for a lot of healthcare providers and definitely patients. In the National Cancer Institute actually has a big dictionary that they say cancer survivors are individuals who are from the time of diagnosis, during and immediately after treatment, and throughout the balance of their life. So you are a survivor at the moment you were diagnosed, because who knows how long that cancer's been around. This is a lot of people have a misconception that cancer survivors are only those who finish treatment. And in some systems, in some ways, that is a definition people use, but more generally, it's more broad than that. And these cancer survivors population is just growing. You can see here, I've drawn a line here. Oh, it didn't take my edit. So I had an edit here in this graph. I went to 2023, so I don't think this is the updated presentation. I apologize. But you can see on this graph, if you go to 2023, it's good around above 18 million cancer survivors. This keeps going up. This is from an article written in 2016. That was a prediction of how much this population will grow. And you can see the 85 plus years is growing even more than the other ones. There are 67% of survivors now living over 5 years, 45% over 10, and 18% over 20. So it's a growing population, more and more older individuals, because treatment's getting better and we're better at providing survivorship care. So these patients are living longer and living more high quality lives. So going back again to survivorship, survivorship is a focus on health and well-being of a person with cancer from the time of diagnosis through the end of their life. And they said this includes the physical, mental, emotional, social, and financial effects of cancer. So it's multidimensional. You can see physical symptoms, psychosocial concerns, quality of life are all tied into this concept. So this is why survivorship is such a really broad and really comprehensive kind of medical care. So it is itself a specialty, cancer survivorship. And I'll talk about more about that as I go along. So this population that we see, cancer survivors, also includes a certain population defined by FORCE, which is facing our risk of cancer empowered. They coined this term previvor, and a previvor is a survivor of a predisposition to cancer who has not had the disease. So there are many individuals who are not cancer survivors, but they may have a really high risk of cancer, maybe because they're mutation carriers, they have a strong family history, or some other predisposing factor that makes them a higher risk. So they need a closer eye on them and more medical care, more screening than others may need. So we include these in our definition in our clinic. All these standards of survivorship care, again, reflect that comprehensive nature. It includes all of these complex needs that cancer survivors have, from one end of the continuum to the other, including all of these different things, which I will talk about. This is kind of the outline of the rest of my talk this morning. So starting with cancer surveillance, screening, and risk assessment. Patients come in all the time and they're always worried, like, what is the chance that this cancer could come back? Because after you've had cancer, you're kind of traumatized by that diagnosis, and it just follows through the rest of your life. And can I develop a new cancer in a different place? And that's a misconception too. A lot of people will think you've had cancer, we don't need to screen for cancer. It's an easy pattern to fall into, but it's not the right thing. All cancer survivors have fear of recurrence and this fear that the cancer is going to come back. Almost everyone. The source I read, it was 80%. I don't think that's high enough, because I'm pretty sure every cancer survivor at some point has had this fear of recurrence. And it's hard to say to patients what's true. They'll say, what's the chance of this coming back? But you can see all the different cancers have different chances of recurrence. This table is a wide range of different cancers, and all these percentages are different. So it's very hard to counsel patients on exactly what's the risk of their cancer coming back. So we have involved many factors in cancer recurrence, but whatever the chances, we tell patients we'll always follow them closely so that if the cancer does come back, we can find it early and we can get them the very best treatment to take care of that cancer and give them the most quality of life they can get. Now, starting talking about surveillance for cancer recurrence, everyone has probably heard of screening, but this is the actual guidelines for the follow-up of cancer patients. And this differs based on cancer type because of all those things I just showed you, the different rates of recurrence. is a defined time between diagnostics, between how often they should be seen in clinic, how often they should have imaging tests. And I'll show you a little bit more about that in a second. There are national guidelines from national organizations that help to guide doctors. That's how we doctor, that give us what these ranges should be and how to and information to be able to counsel patients better. But then we need to tailor them very carefully, either based on maybe we have institutional recommendations or based on the individualized patient. And here you can see this is two sets of guidelines for endometrial cancer surveillance. The National Comprehensive Cancer Network on the left has a certain set of physical exam, labs, and imaging. And then the Society of Gynecologic Oncology has similar, but in some cases, slightly different recommendations. I'm not going to get into the weeds there, just to show you these differences. And here's a table. We had a discussion with our team of gynecologic oncology a couple of years ago and came up with more fine tailored recommendations based on our institution. So screening for new primary cancers, y'all have probably heard of. Early detection, including mammograms, pap smears, HPVs, colonoscopy or stool cards with FIT tests, low dose CT scans for lung cancer, and PSA to a little lesser extent. These generally follow the USPSTF guidelines. I know that's a mouthful. It's the United States Preventive Services Task Force. And I want to come back to this consideration of risks versus benefits. We'll talk a little more about that, but to review, the USPSTF is that big organization, again, guidelines for doctors so they can doctor, and they tell us what are the recommendations, how often should someone get a colonoscopy, when should they start? And they have a table like this for every type of screening, and how, based on the evidence that exists in the literature at the time that they did the review, they update these about every 4 years. And what the literature says. Is there a vast majority of literature that's saying this is beneficial or it's harmful? And it's all really a weight of the risks versus benefits. And coming back to this slide, talking about the consideration of risks and benefits, this early detection is not a one size fits all. The USPSTF says certain things about when to start all these testing, how often to do them, but you have to take a look at your particular patient. And it may not be really necessary for your patient who had rectal cancer 6 years ago to get a mammogram every single year. And it's really a discussion with the patient about those risks versus benefits. What are the potential harms of screening so often or continuing screening, say past age 75, when some recommendations don't really have anything after age 75? So it's a tricky discussion, again, in emphasizing how important the comprehensive nature of the assessment is, which is what we do also, is this cancer risk assessment, because we have to take into account treatment-related secondary cancers. We have to deep dive into the family history because that can affect how we are making our recommendations. Impact of lifestyle and exposures. Has someone smoked? Did they have a history of drinking? Are the obvious ones, but also, are they overweight? Do they get enough activity? What is their diet like? So all of these things play a role in how we counsel patients, as well as genetic predisposition, of course. Those previvors have different recommendations than some of our survivors. We have certain risk models which can help us, which take into account all these different risk factors and can help us to customize and to do the correct type of screening for patients. But you see how kind of complex the nature of these aspects are. And this isn't always something that's within the purview of another specialist in oncology or in general primary care. So we kind of take a finer look at it. Next, talking about monitoring and managing treatment side effects, which is a large part of what we do, of course. And here I need to define the difference between a long-term side effect and a latent side effect. A long-term is something that happens when the patient's getting treatments. Say they start developing pins and needles neuropathy in their fingers and toes, and this may persist over years, may persist, only to the end of treatment. And latent side effects are something that might not appear until many years after treatment completion. Sometimes patients get more fatigued about 2 or 3 years out for who knows why. Or sometimes they'll get heart problems developing after 10 or 20 years. So it's important for these patients to continue following up with doctors that have a keen eye to this. Again, talking about the fatigue, this significantly affects the quality of life for patients and affects a lot of survivors. This is a broad range, 15 to 90%. It really depends on the study, but pretty much most survivors will experience this, especially those who have advanced disease. That's the stage 3 and stage 4 cancer. And about a third will have fatigue for years. And you do all the work up under the sun and treat them as best you can, but it's very tricky to try to drill this down. Chemo-induced peripheral neuropathy, like I said, is a problem a lot of the survivors experience, especially those who have had a platinum-based chemotherapy. In breast cancer and colorectal cancer, there are certain chemotherapies that are prone to have this complication arise. It can cause chronic pain that patients just can't get away from, neurologic dysfunction. We do have some medications that can help. PT and OT can really be helpful, especially when patients are having problems with balance due to the numbness in their feet. And then acupuncture is something that's been shown to help with neuropathy symptoms as well. Cancer-associated cognitive dysfunction can be very frustrating for patients. They just can't think about things as clearly as they used to. They can't remember things. This is the classic chemo brain, as we call it, but may persist. And you can see this with neuropsychologic testing or imaging, which you can order at UIC. Hoping to have that guy talk later this year. Cognitive rehab is a thing. There are medications like Adderall or Vyvanse that can help with mental clarity. Exercise is shown to improve cognitive dysfunction as well as meditation. So that's something I recommend to a lot of patients. Cardiovascular disease is more patients are at risk with this growing population of survivors, like I said, more and more over 85. Compared to a control group, 15 times the rate of heart failure, 10 times the rate of cardiovascular disease, and 9 times the rate of stroke. So this is definitely a significant factor. And this may be in part due to that cancer survivors have been dealing with cancer for a good part of their lives, and they may not be paying attention to what they're eating or that they should be taking a cholesterol medication. So that's a very tough thing we need to work on with their other doctors. And in particular, one side effect is anthracyclines are implicated. So in breast cancer, these patients are typically treated with a certain combination of chemotherapy, which includes adriamycin. And a patient who's had this medication needs to have an annual echo echocardiogram because they are at higher risk of developing heart failure 10 to 20 years out from their treatment. Psychosocial concerns are vast. Anxiety and depression, again, because of that fear of recurrence that many survivors experience. They may have post-traumatic stress because of what they went through. It's very taxing and very traumatic. And fertility and family planning can be very stressful for patients as well. And then the physical problems, of course, the chronic pain and weakness, lymphedema, which is common for patients who have breast cancer and had a lymph node dissection, or endometrial cancer and had a pelvic lymph node dissection. And there are different treatments for that as well. Pelvic floor dysfunction is a very significant problem. Women who have had hysterectomies or gynecologic type surgeries or any other surgery involving the pelvis can have this dysfunction of the muscles that leads to incontinence. Hormone-related symptoms can be problematic because chemo for any type of cancer generally, in most cases, will just knock out the ovaries. Sexual dysfunction goes hand in hand with that. And I thought I had one more, but you can see there are many different side effects, and it takes a keen eye to these specific problems. So next I want to talk about how we can work with other doctors in trying to help with preventative healthcare and evaluating and treating these comorbidities, helping to manage the health long-term of all of these cancer survivors, because like I said, their preventive care may have lapsed. They may have not seen a primary doctor for 2-3 years and lost touch with them. They have poor control of their diabetes or their hypertension. And they may not be up to date with certain lab tests or vaccines, and may have things you can do to help to improve their health and healthcare. So we encourage all survivors to establish with a primary care provider for routine healthcare. It takes a lot of different providers to help take care of these patients, and a primary care provider can help with managing those chronic conditions, in assessing their physical status and mental health, reviewing their medication use, because these survivors are typically on many meds, and encouraging healthy behaviors. I think that's one of the big things that we do in survivorship as well. We almost serve as kind of health coaches to help to get patients with better habits to help to improve these different health factors along with the PCP, and then reducing those risk factors that, are many. Finally, talking about care coordination and providing resources for patients. So again, it's very comprehensive, the care for patients. You can see survivorship and primary care up at the top there, but includes many forms of oncology, genetic counseling, behavioral health, financial counseling, spiritual counseling, nutrition. So again, a large team to adequately care for these patients. And within survivorship, to recap, we talk about the surveillance and follow-up with the oncology specialist, healthcare management with the primary care providers, referral to non-oncology medical specialties. So if, for example, we'll have a colorectal cancer survivor who just has general GI issues, that may not necessarily be a referral back to their oncologist. Maybe we do some imaging to evaluate for recurrence, but they may have an irritable bowel syndrome developing and need a specialty care that we can't provide, that oncology can't provide. And then we refer to many, many different supportive services. There are many ancillary services at UIC that help us with patient-specific issues. Things like neurology that may help with the neuropathy. They have finer testing that's not necessarily a specialist, but maybe more supportive, or neuropsychological testing that can help to define a patient's neurocognitive dysfunction and strategies for helping with that, or financial counseling, social work, things like that. And then we can also provide resources for the cancer support organizations external to UIC as well. And I have some more examples of these internal referrals. Again, just any specialty you can think of, essentially. And the supportive services being a lot of those therapies. We refer to behavioral health a whole lot, especially at Miles Square, nutrition, fertility, and we are working on trying to develop a better system for delivering information to providers, to patients about the supportive services at UIC. So stay tuned for all of that. And if you want to be involved with that, please let me know so that we can get you on our team. Let's see. External referrals, again, many different support organizations that we are involved with and we talk to patients about sometimes, or patients will come to us and say, hey, I'm from Alice Wings, and it's a big network out there and there are lots of patients that we can help. And overall, you can see how all these different facets of looking at patients' comprehensive medical picture really serves to empower patients. And I feel like I am ending my clinical care component with UIC, but I do feel like many patients that I've been seeing, I've just been able to help them to feel more at ease with their medical care because they know how to navigate it better. And I advocate for them and teach them how to advocate for themselves so that they can ask questions and they can really feel like they are empowered to take charge of everything, and give them hope about having a better quality of life and that things can be better, because that's very important for survivors to hold on to that and to bring that up very frequently. So UIH survivorship team, again, is continuing to expand our survivorship clinical program. I am stepping back, but we are planning on hiring a new provider that will be able to see more patients, hopefully, and enhancing the awareness and use of supportive services, like I said, to try to deliver that information to providers and patients better. And then we are always trying to collaborate with oncology groups and primary care, just to deliver all of this care in a better, more organized fashion so patients are better supported. If you want to refer a patient to cancer survivorship, you can place an EPIC referral for adult cancer survivorship, or call or text Kristen Anderson. She's our primary nurse who talks. She's like kind of the gateway for patients. And here's her phone number. I don't know if everyone here is clinical and would use this information, but we'll definitely spread this around. Does anyone have any questions? Go ahead and unmute. Sorry, my dog is kind of growling here. No questions? Oop, there's my dog. Yeah, that is all talk. Like I said, I keep it simple. I will be right back though, actually, because she's gonna keep barking her head off. Sorry about that. Yeah, so that was just a brief overview of what we do at Survivorship. Maybe inspire some of you to refer patients in. We see all patients at any stage of diagnosis or treatment. And yeah, are happy to see any and all of your patients or friends or anyone you want to have talk to us. Just have them give us a call. So Genesis will post this recording and the slides after the presentation, so you can refer back to it and to get in touch with us. Really, no questions, guys? Come on.
I just wanted to say that we're gonna have, Beverly has a question, but just real quick, since I'm unmuted already, we're gonna have, we're starting to plan a survivorship event again for this year, but it'll be in person now. So in June, we'll most likely have this event. So I'll, keep everyone updated, but basically we want to connect patients to resources. And I know Yaz is on the call, so we'll probably reach out to Yaz and everybody else just to, like Dr. Manst is saying, just make it a holistic approach. So have people find a community and like people that they connect with, and also, talk more about the integrative medicine. And then there's also in-person classes for cancer survivors at Miles Square right now going on. So we I'll send the flyer out too, so everybody knows what classes are going on, and you can, let your patients know as well.
Yeah, our patients have really loved those classes. By the way, Genesis, I spoke with our patient who went to the nutrition class and she just really loved it.
Good. I'm glad.
So Beverly, what do you got for us?
Good morning. Thank you so much for the presentation. I wanted to ask, as I know when the survivorship clinic started, I asked this question and I wanted to know if it's kind of something that is still worked on or talked about. Have you thought about having a support group? I know there are different activities that the Cancer Center is working with different organizations, but thinking about for patients having a support group for them.
We usually refer patients that we feel like need a lot more support or could benefit from a support group. It's talking to our patients first, but we introduce them to wellness house services. And we know there are many other support groups across Chicago that we can provide information on. That's exactly what we want to talk about at our event, is how to connect patients with these groups that already exist. They're at Wellness House or at American Cancer Society. I know Alice Wings has a couple for Spanish speaking. So really creating that. We have not yet made a support group just for our patients. But that is something to consider down the line. Genesis, write that one down.
Yeah, and actually, at Miles Square, Wellness House is conducting an in-person support group for women of color specifically. And I know that they're planning on expanding more of their programming. So, I know that could be an option too for, just a general one that's not necessarily only for women of color, maybe like specific for disease type or whatever the case is. But right now it is going on. It's like twice a month on Tuesdays. So I'll send that out with that same flyer.
Very cool. Yeah, Deanna.
Yeah, hi there. I'm Deanna Belandi, and we've not met in person. I've met lots of you, but you and I haven't met in person. But I'm the new marketing and communications director for the Cancer Center. I've been here since October, and I was curious where you're stepping back to. I didn't realize that. I was curious what you're how you're going to be doing.
Yeah, so I am continuing with UIC 1 day a week, but more in the context of educational, kind of like continuing the lecture series and didactics for our team. Okay. And then also our survivorship event, wellness house events, really staying involved in that circle of things. I'm stepping back from clinical care though, and I am actually opening my own practice. So that'll be coming later this spring.
Cool. Congratulations. Yeah. And I look forward to seeing you around here.
Yeah, I probably won't be in the office that much, but yeah, like I said, I get a lot of satisfaction out of the speaking with patients, counseling patients, a lot of the lifestyle medicine, the preventive medicine. And since that was my training, along with integrative medicine, is where my path is going to be going. So I want to continue seeing these patients, but, continuing to encourage them to keep up with survivorship, of course, because it's a very useful resource. But maybe also checking in with patients to help them to continue to build their advocacy powers and improve their lifestyles.
Well, great. All best wishes in that.
Thanks, Deanna. Nice to finally meet you. I know we've communicated via email, and we will get
Right.
in touch, because, like I said, the expanding the educational information and information about services and everything like that, we want to try to find a place to house that, maybe on the Cancer Center website, maybe something that we could talk about further. So we need to have meetings.
Absolutely. Great. I look forward to it.
Yeah, that is on the pipe.
Terrific.
Cool. Anyone else have anything to say?
This is Tamara. I was just going to comment to add to the long-term, what I've heard from a couple young survivors is career counseling and work stuff, and Cancer and Careers does really great work. And I think that it is, nobody warns people, and the statistics show that there are massive career changes and shifts in income and stuff like that. So I would it's financial, but there's also this piece of like, what do I do with my life now? So I would just add that to the list.
Yeah, I'm putting that in the presentation right now. So so that's going to be, because I think I put triage cancer somewhere for like that financial component, but the career driven cancer is definitely, that is a huge thing. Cancer patients have a hard time getting back to work, Tamara very well. And some of our patients have these debilitating side effects that preclude them from working, and how do they get back into that? What can they do now that they have, chronic lymphedema, or, those things really impact our patients.
And Cancer and Careers has like free like resume stuff and career workshops and stuff like that. So they're actually a really good resource, and they do conferences. They do like a Midwest conference. So that's actually the only resource that I know. But they're a really good resource for sure.
I've heard more buzz around them lately too. So I think they're growing. So definitely. Does the American Cancer Society do anything around that?
I don't think they do, not that I know of. They might, it might be new, but I don't know of anything.
That would make sense for them to enter that area. So we'll see. We'll have to stay tuned and poke them a little bit.
Yeah, it's a big topic.
Yeah, it really is. And thank you for pointing that out to me, and for me to include that in this presentation, because I like to widely distribute this. Again, this has been recorded, so and I can give this again. I usually present to the oncology fellows every year, and at least once a year. I might present even a couple times, I don't know. And so this presentation is definitely one to include all of that into. So thank you. You got anything from you, buddy? Is she listening?
I don't. I'm multitasking here, but good luck in this endeavor. I'll turn my camera on for a second too. I don't know, even know if I'm camera ready. Probably not. Hello. But yeah, no, this was a great presentation. It is much needed. If you could do more of this to clinicians across the way, that would be great. Yeah. I'm actually attending a grand round on young people with cancer today. So if you could keep educating providers with content like this, that would be a huge plus.
Yeah. Yeah, that would be a great thing to find more groups to present to, and yeah, do a grand rounds or something. And yeah, I feel like this is a lot of information in a little presentation. It's if I went too much further out of the presentation, it might be a little bit too much.
Right, but no, it's a great high level. And I love the addition tomorrow of the
Yeah,
employment and educational reentry.
I really love that.
Yeah, yeah.
The other thing that and I'm hesitant to say this, but I'm wondering if you could adapt this for a survivor audience, because I think that, I mean, like looking at it as a survivor, there's a lot of really scary stuff, like, oh, the heart disease stuff and the increased rate of this, and you know, the danger of that. But I also think that no one tells survivors that this is coming down the pipe, and that if there's a way to be sort of to encourage connection with a primary care provider and frame it in a way like that's not too scary or debilitating.
Yeah, in a way that they can do something about it. You know,
Yes,
if they
yes.
were never told that they were going to have heart issues, then they don't have a chance to do other things that could mitigate or at least prolong it. You know, if you're not told it's going to happen, you can't do anything about it.
Or I think a lot of people just live with some of the long-term, you know,
The
side effects.
incontinence, the muscle pain, and they don't know
The
that
fatigue.
their cancer treatment.
Right. And to talk to a PCP, and if the PCP doesn't know, then find a PCP who is more specialized.
Yeah, not all PCPs are totally up on this, and that
Yes.
again is a good reason for, you know, us to continue to get out there presenting and advancing these educational efforts, as is the plan of myself and our team.
So if you want to do a presentation for survivors, if we want to talk about it, we would love to do that through Yaz.
Yeah, and I would do it through Yaz, I would do it through Wellness House, because I do give their top doc, and this might be interesting too, and I'll forward to you. I was also considering giving the talk. I did their top doc series in December and talked about lifestyle and wellness in survivorship, and like getting good sleep, getting what are the exercise recommendations, like what, demystifying all the information, right? Because it's all just really fragmented and all over the place, and it's hard to bring it all in one place and together for patients. So,
and that's called a survivorship care plan.
Right. I was going to say, they just don't often don't get that from their oncology team. Sometimes they do, and that's changing, but they don't always get it. And it depends on where they get their care. And if they're at a, you know, a community hospital or a private oncology office, then chances are they're not going to get that.
Yeah, it's the care plans have been de-emphasized.
It's a great way to put it. I think their value has to be proven, and that's just going to take a little time, but they're an excellent tool.
There are multiple sources. I remember working with Dr. Susan Hong, my first director, who hated care plans from day one and thought they were a massive waste of time. And that the studies were showing that patients, you know, knew a little bit more about things, but really weren't greatly affected by it. And maybe because this part of the care plan wasn't that well fleshed out, I don't know.
Yeah. Well, the EMRs are cumbersome in that it was a massive waste of time for providers because it isn't automated for the actual treatment modalities, the treatment protocols to automatically be filtered into a survivorship. It's
very hard. It's very difficult even to put in stages cancers into Epic. It's tough to track that information and to have consistent information across the chart. Some people have 3 diagnoses of endometrial cancer in their charts, and it's just like it makes no sense. And I go through and try to prune what I can and try to make things more clear and put in the actual, because I go through with my new patients, I have a very extensive template where I get into the details of all their diagnosis, all the markers, all the diagnostic factors, all the treatment factors,
Is
family.
that a template that auto fills, or you have to manually put
I
that
have
together?
to manually put
Yeah,
all of it
and
in.
there we go. There's the time.
It
Yeah,
doesn't come in. Yeah, it's very time consuming.
great
And
that you do that. Sorry
yeah,
that you have to, that it isn't automated.
yeah, but that's, part of survivorship, because a lot of patients, because they don't get those care plans, I will say Gyn-Onc has been good about filling those out and getting they have like an endometrial cancer care plan for all their endometrial cancer patients, but that's not universal. And it's not every service that has that. So it is a challenge. And definitely something we need to further work on. And yeah. So thanks everyone for attending. Thanks for the discussion. And I'll touch base with all of you at some point, I'm sure, about these various projects, Deanna and Tamara. So yeah, thanks very much. And that is all. Next month we have Fran Lewis will talk to us about the family aspect of survivorship and children actually with parents with cancer. So it's been very much the basis of her work, and we're doing some close research with her. So thank you for the care plan generator, Betty. We'll look more into that. That may be one of the things on our plate. We'll have to look into that. Oops. Okay. Thanks, everyone. Have a great rest of your week.
Thank you. Have a good one.
Bye.
Thanks.